All right, I'm super excited. Nicole, do you want to give a brief introduction of yourself?
Sure. Nicole Hayes. I've been at BCBA for 11 years, and then I have master's degrees in forensic psychology and social work. I've worked in in-home clinic, telehealth, school-based services, and then also worked um, for the Army Substance Abuse Program and Family Advocacy Programs, as well as I'm an Army veteran, so kind of an eclectic work experience here.
Yeah, I got to chat with Nicole a little bit before we started this, and I was like, you have so much experience. I feel like I'd love to pick your brain. So that's how it ended up into an interview style. Um, so, Nicole, I know you mentioned that you were in ABA, you became a BCBA, and then you paused that and became a licensed social worker. Is that correct?
Yes.
Okay. So I guess I'm curious, what led you to wanting to pursue an LMSW and then go back to the field? And maybe what differences have you seen from that?
Yeah. Um, so I did my ABA coursework at the Chicago School of Professional Psychology, and while I was there, I participated in something called the um, Global Hope Training Initiative. And so part of that was you spent a semester studying trauma with a cohort of students from Rwanda. And then the group from the Chicago School went there to help implement the train the trainer workshops, basically, with school staff who lived through the 1994 genocide. So I feel like that experience, obviously, life changing anytime you go and work with people, talk with people from, a completely different culture and experience. But it shifted how I was understanding behavior, and kind of started my journey with wanting to learn more about trauma. And so that made me really reconsider, as I started my career in ABA, reconsider, a lot of the things that I was observing, how trauma can show up behaviorally compared to, the way that PTSD is very narrowly portrayed. Sometimes trauma responses might look like um, a whole lot of different things. And so I felt like part of it was that I was noticing these things in my clients, and I wanted to go back and really get a better understanding, because I felt like the more I learned about trauma and what it could look like, I was really, really interested in um, why there's such a variability in how people respond to what could constitute a traumatic event. And that gap in knowledge, I guess, is the biggest thing that made me want to leave and just get more education specific to that, and then use that moving forward. Um, so when I um, came, back into the field, I started out working in clinic, and I felt like, um, you know, a lot of the behavior um, really could be attributed to experiences, but not necessarily in the way that I had been exposed to the concept of trauma informed care prior to going back for the social work. So, I guess as far as like what did I see differently, behavior analysis isn't wrong in how we approach even behavior that could be related to trauma, but it was more like I felt like it's incomplete until we take into consideration things like learner readiness, regulation, environmental context. And so the additional training that I got in child development, attachment, trauma, it helped me recognize how chronic stress and environmental histories can really function as setting events, and then that's going to influence like the client's ability to engage in skill acquisition programming, it's going to impact their reinforcement sensitivity. Um, and it also made me more aware of the language that's used and the everyday clinical assumptions that are happening. Um, you know, within the field of ABA, I think there's still a little bit of ableist framing that's happening, and that can really shape client experiences and their clinical outcomes, and our clinical decision making as providers if we're not aware and noticing it. So I think those are the biggest shifts that changed my perspective when I came back into the field.
Mm, yeah, I really resonated with when you said it's behavior analysis is just part of it, right? And there's just so much more and so much more context or modalities. I think I learned that pretty early on, at least 3, 4 years ago when I started my company. I was like, I think it's common that we're in the field and we see behaviors happen in person in work, and we're at some point, especially when they're the extreme ones, we're like, there's got to be something else going on. Especially when the behavior plans are not working and we've tried everything and we're seeing really highly dysregulated behaviors. And I think a lot of us question, like, is there something else, or some other way that we're missing of how to support these clients and children? Um, I guess for you, how would you clinically define trauma? Like, what does that look like in our field? And I don't know if you would define that differently versus like in social work.
Yeah. Um, so I love attachment theory. So I think I tend to be biased toward like a developmental framework, thinking of trauma as like a disruption in that optimal development and functioning from a brain and nervous system perspective. Um, and within behavior analysis, that really relates to the conditioning experience of those um, experiences. But I definitely think we need to shift away from conceptualizing trauma as a specific event, and more think of it as a learning condition. It's created by this, possibly an overwhelming event or just chronic stress. And that's altering how the client is, you know, processing experiences, responding to the environment, perceiving safety. And so, like, it's really focused more on the response and less of that, singular event that I think a lot of times trauma is conceptualized as. Um, and we can observe behavior and response patterns that give us a good, or not a good, but a better indicator of how um, trauma is impacting the client. So, again, bringing it into like a behavior analytic perspective, it's trauma is important because it's changing things like stimulus control, and it's going to affect learning readiness. It's going to affect motivating operations. And so it's less like, do they have a traumatic experience or do they have trauma in their history, but more, how might this person's history be affecting how behavior is functioning for them now? So I think, kind of putting together like what you might see in other fields, or a more mentalistic approach of what the trauma experience is, but then really grounding it in behavior analysis. What are the impacts again on the things like motivating operations and stimulus control that's affecting the behavior now? Because when there's trauma, we're going to have to look beyond, what's happening in this very present moment.
Yeah, yeah, I agree. I remember in my training, when we rule out those, environmental factors like, oh, medication, different things. But even now, as I look back, being trauma informed now, I'm like, there is still so much that we didn't look at, especially from a trauma lens, right? Um, Sorry, my internet's unstable. Making sure you guys can hear me okay. But yeah, I feel like now when I work with clients, I look at like, I'll ask the caregivers, what is their attachment style? What is their history of punishment? What was their relationship like with their parents, right? That gives me an idea of what that looks like with their relationship with their child. And so many questions that I ask now in that assessment, that intake, that we don't go over in a traditional medical model approach. Um, yeah,
And
yeah,
I was gonna say with the even with the medical model and the way that the trauma is assessed, I mean, there's such a huge gap for a lot of the clients that we work with in being able to identify and diagnose trauma. You know, if there's communication barriers, you know, a big part of the diagnostic criteria for PTSD specifically is that um, perception that there was a threat of loss of life. But if we have somebody who's got barriers to communicating, you know, we're not really sure what their perception was from a whole variety of experiences, you know, and that was one thing that I felt like I was seeing with clients that made me want to go back to school because, um, you know, it was experiences that looked like they should be every day. You know, they're not anything that should be causing the response that was happening. And there really wasn't a reinforcement history of escape. And yet, these are the reactions that I was seeing kids have to the environmental stimulus, and it didn't make sense from that antecedent behavior consequence perspective. And so it felt like there's something else. There has to be something else that's happening here that, you know, I haven't been trained to identify or pick up on.
yeah. Yeah, I recall when I was working in a school, there was one child, he had a speech delay, right? So I think on the surface, everyone just sees like, oh, he just has a speech delay. But then as I got to know the backstory, he had a lot of trauma. I mean, apparently his house had burnt down. He lost his home like in minutes, and there's so much entailed after that, right? And I think traumas like those, especially because he was diagnosed with ASD, but then things like that happening on top of that. And I don't know if you have any input on this, Nicole. Like, I feel like there have been instances where children can lose their speech or lose speaking capability because of a really sudden, extreme traumatic event, right? But I think we don't, if you don't study trauma or you're not aware of it, you just think, oh, it's because he's autistic and he has a speech delay type of thing. But I feel like that opened
Yeah,
my eyes up a lot.
yeah, yeah. And I mean, differential diagnosis is definitely possible, but I think probably a lot less accessible than we'd like for it to be, you know, a lot, especially within the insurance model. You know, the ICD gives a little bit more broad criteria when they're looking at trauma compared to the DSM-5. But yeah, there's a lot of barriers to assessing the impact of trauma um, within the neurodivergent population for sure.
So, speaking of the DSM, how do you feel like trauma is described in the DSM, and how does that differ in how we in the ABA field might approach trauma-informed ABA? Like maybe where do they overlap or where do they differ?
So fingers crossed for a better definition in the DSM version 6. But you know, the DSM is very specifically diagnosing a trauma related disorder, right? We hear about PTSD, and that is, you know, that one specific diagnosis. It's not really talking about trauma as a human experience. Um, you know, within trauma informed ABA, we're not looking for a diagnosis. You know, we're not, you know, even treating trauma disorders, but it's more of like a practice framework to acknowledge, you know, there's a trauma history, there's a stress history. Capacity is going to be impacted by those experiences and that trauma. And there's an overlap because both recognize that traumatic stress does produce measurable changes, but they differ a lot because we're not, trying to diagnose or even treat clinically, but we're adjusting the environment, we're adjusting our teaching strategies so that learning can be safe and effective. So I think, the DSM is who qualifies for a diagnosis of PTSD. Looking at this person, do they qualify for a diagnosis based on this set criteria? Whereas trauma-informed ABA is more along the lines of, how can we ethically teach some of these skills when we know that there are experiences that are going to have affected their brain, and they're responding to the environment.
Yeah, yeah, I love that you mentioned like how do we in the field ethically teach that or facilitate that? Obviously, we do not treat trauma. That's out of our scope of competence unless you have the experience and licensure. But I guess like how do you feel like BCBAs can differentiate between learned behavior patterns and behaviors that are influenced by traumatic stress? I feel like that's a common like, well, we don't know the difference and how would we know how to respond?
Yeah. Um, I don't I don't necessarily know that it's important to choose or be able to differentiate like this is learned behavior and this is because of their stress experiences. Um, but what you would want to change is being able to analyze the patterns of behavior across context so that you can identify um, changes in interventions that might need to happen. So like the learned behavior patterns, our literature demonstrates that that tend to be somewhat predictable across environments. Learned behavior is going to respond pretty well to consistent contingency changes, right? That's kind of one of the foundations of our history of ABA. Whereas behavior that's related to a stress response, it's not necessarily going to be as predictable across contexts. It's you're going to see more drastic fluctuations in capacity, just based on the where they're at that day, any environmental cues that may have signaled it's not safe. You know, um, they might exhibit some more variable responding to traditional strategies. So you're not going to necessarily have that same clear trajectory or trend as you're progressing. So I think, yeah, it's I guess I think more important to be able to identify those patterns and be able to see, okay, that I know what the reinforcement history is for this particular context, and we're still seeing, pretty rapid escalation of behavior following demand. So solid chance that that behavior is not related to the reinforcement history, but there's something else happening. So let's take a step back and let's figure out what about this context is signaling, that this isn't safe, or, that for some reason we need to escape this scenario for the client.
Yeah.
Um, yeah.
Yeah, that was so like I from what I heard, like a sign could be like, okay, there's an escalation even after the behavior plan is being implemented. That could potentially be a signal that there's something more. Is
Yeah.
there anything else that you would say that kind of has indicators?
I think, you can, gosh, there's so many. um, I think more like I would look for cues of like contextual safety for the kids. Are there is there consistency that you can identify that they're they respond better in certain contexts? Does behavior improve when you reduce environmental pressure rather than just the contingencies. If you're changing something about the presentation, something about the environment, um, rather than, did they access reinforcement or not, that might give you a clue. Again, like there's something um, there's something a little bit more happening than just that. Um, Again, antecedent behavior consequence model. Um, I think if you are noticing a consistent, either hyper or hypo arousal that is not necessarily contextually doesn't make sense. I think if you're working in a clinic, for example, and you've got 3 and 4 year olds, you're gonna expect that they get really excited and they're running around and yelling in certain environments. But if there are, sudden or atypical for the client changes in their um, state of arousal, that might also give you an indicator like, oh, there's something beyond just, access to or withholding of reinforcement that's impacting their responding right now.
Yeah. Yeah. I think you mentioned hypo and hyperarousal. I'm familiar with that, but for those who may not be familiar, what is that or what does that look like?
Yeah. So you can have different, I guess, types of response to stress. You might have people who, or clients who are hyper aroused, and it's anything from being, really um, loud, really energetic, really defiant can be kind of what that looks like. Um, really hyper vigilant, always kind of on edge. Or you can have more of like what looks like that shutdown where, you have a more flat affect. They're less, they go from being, pretty responsive to like, we cannot get them to respond to anything. They're not wanting to engage, verbal responding or, communication attempts kind of, um, bottom out. You're not getting that from them. And that's not saying that anytime any of those things happen, it's related to trauma, but it can be one of those indicators that there's um, something going on for them. And that's where, again, like, your analysis becomes really important to look for those patterns. If it's very consistently one context, one presentation of a specific demand, and that historically they've been reinforced for escaping demands that they don't want to do. It could be that, it doesn't necessarily have to mean that there's trauma or, stress related responding, but it's important to be considering those variables, um,
Yeah.
when you're working with them.
Yeah, that makes sense. Yeah, it's very nuanced. I mean, you had kind of mentioned how that might show up as hypo or hyperarousal, but from a neurodevelopmental perspective, how do you feel like that type of stress can influence observable behaviors that we might see with our clients?
Yeah. Yes. So there are structural brain changes that happen with trauma and chronic stress. So with chronic stress or trauma, like, basically the brain shifts to survival efficiency rather than, learning opportunities. So in a perfect um, world, kids will have the opportunity to develop feeling safe and connected, and their brain is wired to take in those opportunities and to build connections. And so when there's disruption to that, stress systems are repeatedly activated. There's changes in the amygdala, so there's going to be increased amygdala reactivity, which is, your fight or flight is going to be activated essentially, and that ties into that hyper or hypo arousal. You're going to see reduced access to prefrontal lobe functions. So that's your inhibition, your flexibility, your ability to engage in problem solving. So, it's in the diagnostic criteria for autism, very rigid behavior, inflexibility, but that's also a stress response. And so it's really, it becomes very important to be able to see as we're looking at this, okay, I want to work on their rigidity. I want to work on their ability to be flexible and responding. Well, is it because they've never been exposed to that skill and we just need to teach that skill, or is there something that's protecting them? So I think you have to think of all the responses as protective more so than maladaptive. Their brain and body, their nervous system are doing what it's wired to do for protection. And so we have to keep that in mind. It's not just a learned behavior, it's a physiological survival response.
Yeah.
I don't know if that really
Yeah, no,
oh,
I
I
think you
think
answered.
you had asked about behavior. So yeah, that's the some of it. What else? I think that's a big part of the behavior that you'll see.
Yeah.
The the hippocampus is also affected when you have pretty consistent, amygdala activation. There's some research that indicates it might just decrease in volume, but that impacts learning because that's where like memory formation is happening. But it also is affecting the way that the brain makes predictions. So that part of the brain is where people are making associations through their experiences, and so if that you know nervous system and amygdala activation is consistently happening, the associations that are forming are going to lean toward there's going to be a punishment bias. It's going to decrease the anticipation of reinforcement and lean more toward like this is going to be a punishing experience, and that's going to create resistance, from them when you're looking at some of the more traditional kind of ABA programming.
Yeah. I really appreciate how when you were talking about, this truly is a protective response, right? When adult or child engage in behaviors, whether that seems maladaptive or not, but a lot of times I feel like as BCBAs, even though we study behavior, we technically know the why, we still sometimes I think fail to realize those underlying neurobiological conditions of like, yeah, it might be for escape or attention or sensory, but like there might be something even deeper below that or beneath that that is driving that they can't necessarily control. And so it's not just, oh, they're just trying to get attention, right? It's truly something they may not either be aware of or control. And also, it's just a natural human response to stress.
Yeah,
Yeah.
especially, if you have kids with very early exposure to trauma, disruptions to attachment, and that can be anything, that can be things that the caregivers might not even have processed as a traumatic experience for their child, but the body and the brain perceived it as a traumatic experience, and so the client is not going to be able to articulate, this happened. That's just how they develop. That's natural to them. That's just what their nervous system does when they encounter certain stimuli in the environment. And so, yeah, it makes it even harder when there's those very early exposures because they're not going to have a conscious awareness that something happened. It's not there's not going to be able to process like this happened, this it was my response, and I can recognize and appreciate that it was adaptive for the situation, because that's all that a trauma response is. It's the body trying to survive that situation or that stress. So it definitely adds complexity to trying to work around, I guess, those histories. And then there's also, I've seen some, I guess, questioning lately of the amount that trauma is being talked about, and saying, every kid can't have trauma. But, I think we actually should err on the side of assuming that, because, the world that we exist in now is very different from even when the a lot of the literature on trauma was was published. And so, like, the things that people are exposed to on a regular basis are not really, I don't want to say normal, but it's not necessarily things I think we were designed to be exposed to on an ongoing basis. So that's one factor. But then there's also research on transgenerational epigenetic inheritance of trauma. And so and that's something that we had talked about in Rwanda. Children who weren't alive during the genocide exhibiting signs of PTSD, that didn't make sense because they didn't have the experience. And there, it wasn't like they were exposed to a lot of conversation about it. Is actually quite the opposite. It wasn't regularly talked about or acknowledged, and yet the trauma seemed to be there. And now there's research that trauma in one generation is going to be expressed on a cellular level in subsequent generations. So if you think about the evolving exposure and the evolving experience of chronic stress that people have now, and then the impact on generations later, I mean, it actually kind of makes sense that we're seeing more of what looks like trauma responses in clients.
Yeah, yeah. When I first discovered epigenetics and just, where things stem from, especially trauma, I was like, it was like a behavior cusp. I was like, oh, my lens of just behavior and so many things just widened. I was like, it makes sense, right? And sometimes we do see those behaviors very early on. And I always think of like epigenetics as like there's multiple ways we can use that as a lens, but I always like to see it as like, especially if you're a parent or mother, to remove that shame because a lot of times, or sometimes it's not like you could be doing the best you can and your child could still, cry a lot or have difficulties and it's not always on you. It's not something, and I think I relate that to behaviors because, our job is to kind of manipulate and shape behaviors to build those skills. But I feel like we can only do so much to some degree. And I feel like when we don't consider those histories like the intergenerational trauma and things like that, it does influence how we, create treatment plans or approach our goals. Um, you had mentioned about, biasy within practitioners. I mean, you kind of had touched on something like that. And I was curious, how do you feel like providers, their own triggers and biases may show up in implementation with our goals, and how should supervision address that ethically?
So I think it's actually really important when we're talking about trauma, or we're talking about, or giving feedback on maybe this should be approached a little bit differently because of a potential for trauma. It's actually really important to make sure that the clinicians are prepared. You mentioned parents, and that's a huge one. The variables that parents are having to juggle, and the world we live in right now is not particularly friendly for parents, especially with kids who have um, more support needs than just, off to school you go. It's there's it's a lot. It's a lot. And yes, even with the epigenetics piece, there's that balance of making sure that they don't feel responsible for that, because I definitely think it could go down that path of, I because I experienced this, now my kids, and it's not really how it works. It's not quite that simple. It almost is more of creating a cellular vulnerability, um, but there's not. It's not like just living as a human in this world. You're definitely setting your future kids up for trauma. Like, that's not how it works. So making sure, of course, that they're not taking that message in. But the same thing with clinicians. Um, I think especially if you've been in the field for a while, um, you know, I know I did things and was asked to do things that now looking back, I'm like, that was not the best choice on our part. That wasn't in the best interest of the client. And, I wish that I had taken a different path in those treatment decisions. So making sure that people are really ready to hear that, um, hear the information about trauma, and hear that you know certain procedures might be causing stress, um, without placing blame on the providers. I think I have good faith in everyone that comes into this field, that everyone's trying to do the best that they can for the clients. I really don't think people come into this field without a passion for making people's lives better. I, you know, I really have hope that that's why the majority of people are here, is because they genuinely care and they genuinely want to um, make people's lives, improve the quality of life. And so, um, yes, with supervision, I think it's important to make sure that um, we're talking about what's most ethical, and disseminating the information that we have now. But also, we should be teaching clinicians how to observe their own behavioral indicators of dysregulation, and, modeling that regulation, being able to take critical feedback too, giving them the space and opportunity to say, hey, like, that was really hard for me to take in. And maybe next time you can do it a little bit differently, or can we figure out um, how you can share that a little differently um, next time, because we need our supervisees to be in a place where they also feel safe, because they're not going to be able to implement at their optimal level, and make clinical decisions at their optimal level, if they're not feeling safe in the environment either. And I think you had asked about triggers, and I think, um, or triggers and biases. And with biases, I think the biggest thing is just wrapping your brain around the fact that you have them. Like, everybody has them, and it's just one of those things, you not necessarily intentionally acting on them, but you really need to take ownership of the fact that, like, by living as a human person in a society of other people, you're going to develop biases, and that's just normal, and that's okay. And it's more about recognizing this might be influencing me, and I need to be able to recognize when something might be a bias of mine, and be able to interpret that. We talk so much about objective observation, but the reality is, like, we're still perceiving what we're observing. And so, as wonderful as we can write our objective definitions and things like that. Like it's still a human being interpreting what they're seeing, and so it just is. It is going to be affected by our own learning history. Um, I think being able to reflect on behavior that you're seeing and accept that maybe it could be viewed from a different lens. One of the things that I've encountered a lot of pushback on is the concept of noncompliance and, you know, the relevance of that in programming, and the need to kind of fix that. The need to say like defiance is a bad thing. Um, Being able to say like, wow, like where is that coming from for me? Can I take a step back and look at how is this behavior affecting the client, not the people around the client in this moment? Um, that's just been a big one historically, that people have a more challenging time kind of viewing their own biases, or you know making sure that clinicians can recognize if they're triggered by escalating behavior. If there's something in their past, I've seen, so many people had um, not the most supportive experience as technicians, and they were left in really vulnerable um, situations that, they probably shouldn't have been required to manage on their own. And that has created almost like a stress response in them. And they're now, as behavior analysts, they have, it's a little bit of a trigger when clients start to escalate. And so, yeah, I think um, it's possible for clinicians to kind of shift in those moments from teaching to really like reacting to their own responding. And so, yeah, supervision really needs to include that piece of recognizing that and being able to respond to that. Um, Even if that means in the moment we're reinforcing behavior because we're recognizing that we're not in a place to respond effectively, like being able to say, you know what, like this trial is not going to work out, and we're just going to keep everyone safe, and we're going to regroup and hopefully, figure out what we can do differently next time. Um, that's another one too. Being able to let go of that idea that we have to have the answer every single time, and we have to be able to have the correct response every single time, because that's not realistic. And so letting go of that, which in a way is kind of another bias. Yeah.
Yeah,
Right. That may have gone on a couple different trajectories.
yeah. That was a lot of good information. I don't know if it's just me, but I was like nodding my head so much because I relate to a lot of what you're sharing, whether that's as an RBT and not being set up for success, or maybe not knowing that I can say, no, I can't manage this case, or being given more goals to run than I can manage with a client and in a very chaotic environment. And I just I really loved when you're talking about we often focus on, we don't focus enough necessarily on what that child or client needs or how they might respond, right? How they might feel about it. But a lot of times it's like, what do the parents want for the child? What does insurance want? So many other stakeholders that we're paying attention to, but are we paying attention enough to like, is this some like gauging how is this child responding to this goal or plan? And yeah, so many things you said. Like, I just think about even crying. I had a course or a training course where I did this, and I had BCBAs watch a video of a child crying for a really, really long time. And then the reflection piece was like, how did that make you feel? Right? Because I think even from a stress or traumatic or somatic approach, we understand that crying in itself is not harmful or bad. It's actually an expression of us releasing a lot of those stress hormones. But it can be stressful for us, right? When we don't know how to respond, we don't know what to do. And again, that history of punishment of maybe those prolonged crying means I'm a bad technician or I'm a bad parent or whatever we have our biases or history of punishment with. And even those things, I'm so surprised sometimes that we're in a therapeutic field or we call it a therapeutic field, but we're not given those skill sets of training of self-reflection, recognizing our own triggers. Even though in the ethics it does talk about the biases, right? But then like what does that actually look like as a professional?
Yeah.
Um, yeah. Okay, I have a question about because you mentioned in your experience, you had mentioned that you do trainings and you do quality assurance. Um, and you're talking about like, yes, supervisors, and we need to be equipped with this. But when it comes to offering feedback for, say, your own supervisees, when do you feel like it's not the right time to give them feedback on like, oh, this is like not a great treatment plan? Why does timing matter?
So yes, it's I think we have to acknowledge the reality that a lot of us work with insurance, and there's going to be timelines and um, expectations and then billable requirements. And so when we're thinking about that, just like we would with a client, you're not going to, what I mean, if we're implementing trauma informed care, we're not going to present challenging um, feedback or challenging tasks when we know that they are not prepared to manage that. And so I think when we're giving feedback, um, you should really check in and make sure that like they're prepared to receive that. And so thinking back, so I was a drill sergeant, went in the Army, and we provided a lot of feedback constantly, ongoing, just and most of it critical feedback to people, just nonstop throughout basic training, right? Um, which it that's kind of what it was designed to do. Is obviously the job is to train people to survive in stressful situations because they're going to eventually or potentially be in life-threatening situations. That's the job, the role. So we would introduce a lot of stress throughout the day. Especially in the initial periods of training, but it was like structured stress, scaffolded stress. So we would put all this stress, but in almost in like an errorless learning way. We're adding environmental stress, and we're adding you know a lot of yelling, right? We're just yelling all the time, and people are doing push-ups, and we're physically exhausting them. But we set up all of the skills to make it so that it was really hard to fail any of it. So they're experiencing this stress, but they're also experiencing success while they're going through it, and that is building those connections. Like, oh, like I'm I'm doing this. Like I'm encountering success even when I'm experiencing a great deal of discomfort, right? So it's like we didn't, even in that situation, we weren't just giving feedback. I mean, like, best of luck, hope that, I mean, we might have said that, but we didn't actually leave them to independently try and survive and get through all of these, completely novel and challenging tasks. So I think we really should implement that kind of framework into like our clinical work and our work as supervisors. Growth for our supervisees, it's gonna require exposure to difficulty. It's gonna require exposure to challenge and um, receiving feedback. But just like with the clients, like we need to know the supervisee's baseline. We need to know what their capacity is, what their learning history is, what does their environment look like, before we are just increasing demand and fading support. So I'm I'm not sure that I've seen that, in a lot of organizations where it's actually like an intentional, structured process for increased demand, increased challenge, giving all this critical feedback with like a very structured plan to also support the skill development based on where they're at, in their, career or their training. So I think that's one thing that I would love to see, um, more in organizations with supervision and leadership among, BCBAs is, it really should be a lot more structured and individualized based on like what their current skill is, what their baseline skill is, and what their capacity is. This we're focusing on trauma. We're not talking about burnout, but that stress is definitely a contributing factor to why we're seeing so many people, sharing on social media or job hopping. It's that constant stress without the supports built in. That and that is another element of, I think, trauma informed application, that we should really be taking into consideration.
Yeah, that makes so much sense. Like when you say it, I'm like, why isn't everyone doing that? Because I think you're right. And as you're sharing that, it made me think about how we emphasize so much on preventative measures, right? And trauma-informed care in some way is preventative measures, but it's also preventative for us as the therapists and clinicians, right? So like you said, like I think we think of creating a behavior plan, there needs to be some big behavior for someone to request that. But in reality, like it can be applicable as a preventative measure, and especially in the work field, especially in the ABA field, where if we were to do kind of what you were recommending and what's necessary, I can't imagine how much better a company can thrive and how much more supported BCBAs and RBTs feel in their work, right?
Yeah. I
Yeah.
think it would ideally, it would happen before, before you have BCBAs who are getting feedback on their treatment plans. It should be happening so much earlier in the process than that, you know, um, and I know not everyone's, program is the same and not everyone's fieldwork experience is the same. Um, but I mean, there's also, I'm not super proficient with the requirements for programs to become accredited, but when it comes to supervision of like people getting their field work hours, I mean there's the guidelines, but I don't know that there's necessarily, a universal, like this should be a framework for what that looks like, and these are the, more in-depth requirements of of supervisors and what that should look like. And um, you know, I feel like from feedback I've gotten from BCBAs in the field, a lot of times that's not what their experience was with supervision and getting their field work, and it doesn't set them up for success. And then we're trying to backtrack and get them to that place themselves. Meanwhile, they're already supervising people, and we're in this cycle of trying to play catch up, but we're not, nearly on the front end of it enough to, um, make the impact I think that we would want to make.
Yeah, yeah, for sure. Yeah. I feel like we could talk hours about that topic, but we
Yes,
are
that
almost
one.
at time, so I'm gonna pause there. But I would love to kind of close this session So, for those who don't know, this is part of the series where I'm calling it Raise Your Voice, the stories that shape us. And it's one, learning from people like Nicole and learning from our experiences, but not just professional, personally, right? Because they're integrated and learning about the hardships and how can we do better? How can we relate? Um, I feel like so much of today touched on so many ethical things that we could dive so much deeper in, but we don't have the time. But I guess my last question to close up is, what would it look like for BCBAs to, I guess, raise their voice or speak up ethically in today's field? What would be your thoughts on that?
I think, you know, um, not rejecting ABA. I feel like there's almost been a split more recently with, the trauma informed side, and then we've got, a group of people who are like, no, like they're old school ABA, like we have all this literature, and it really, like, it's not, they're not promoting separate things. Everybody is actually saying kind of the same thing, just in different ways. And so I think, raising your voice ethically now is just being, um, open to asking like more in-depth clinical questions, being willing to examine your own assumptions about behavior, and assumptions, that maybe you were taught and have been reinforced during your experience in the field. And then, applying scientific curiosity to our literature, to our assessment processes. You know, there's been that argument that there's insufficient literature to support trauma-informed ABA. Well, we're the ones responsible for the literature. If we are not conducting the research, if we are not, um, going back through our, existing literature and saying, well, if we apply this lens that we know now to this research, there are a lot more holes than maybe we might have initially seen, in these standard procedures. So, not just accepting where we're at, but continuing to try and grow. And then being open to listening, to dissent from people, I think is a huge thing. There is a lot of, opposition, not, widespread, but there are groups that are very opposed to, um, the use of behavior analysis, particularly with neurodivergent kids. And I think it's really important to hear what they're saying, so that we can, again, apply that scientific lens to what is going on. Like, where is this coming from? Because, there's not a whole lot of benefit to people just saying, this is a horrible thing. And it's not just, groups of random people. There are OTs who are opposed to ABA. There's speech therapists who are opposed. There were social workers who, believe that anything behaviorism is terrible. So if we can get to a place where we take that feedback, and instead of saying, well, that's not how I do things, that's not what ABA looks like, and instead apply, scientific curiosity to where is that coming from, I think that will make a huge difference with what ethics looks like in our field. And I think a lot of people, might have those questions. They might experience that, you know, maybe maybe I too wonder why things have looked like this, or why someone would do this. But because of the structure of, organizations, that, again, the insurance requirements, you've got billable requirements, they don't know how to move forward with all of that. So yeah, being able to say like, okay, this is this is personally, I question this policy, and I'm questioning this, um, you know, whatever these procedures, but taking it that next step of, okay, well, looking at this from, a behavior analytic perspective, let's figure out what's going on, and, what can I actually learn about this?
Yeah, that's a really big challenge. I feel like that's something that really, that's a lot to think about. And it sounds like a lot of it is just going back to our basic training. So, yeah, what does it look like from an objective lens, like that foundational training we were initially taught, but maybe not adequately modeled and trained in? Um, yeah, thank you for sharing that, Nicole. I feel like I gained so many things to think about and reflect on, even as myself as a clinician, even as a trauma-informed, behavior analyst. It's still a lot to think about. It's such an ongoing thing to work on.